Okay, so pulmonary edema. Edema just means fluid or something else fluid like pus or blood in the pulmonary system. That's all it means. The most common cause of pulmonary edema is congestive heart failure, specifically left sided congestive heart failure. And we're going to talk about that when we get into the cardiovascular emergencies. But basically, pulmonary edema is caused because, for whatever reason, we have damaged the actual pump. We have actually damaged the left side of the heart, whether it be some kind of traumatic event or possibly a heart attack. And the left side of the heart, it's still pumping, but not as fast as the right side. So, if you guys remember the blood flow through the heart, if my pump is pumping slower on the left hand side than the right hand side, that fluid is going to start backing up into the lungs because that fluid is supposed to go into the left side of the heart in order to be ejected into the rest of the body. So the because the right side is still pumping efficiently, the left side is pumping a little bit slower than the right side. It's not able to get all the fluid out of the lungs as it's supposed to, which will actually cause pulmonary edema. And this causes leaky capillaries, and it usually interferes with gas exchange at the alveoli level. So again, this is fluid in the alveoli, so that we are not able to get that gas exchange. It's much harder for oxygen to cross over through water in order to be absorbed into the bloodstream. It still can be done, so we are still doing a little bit of gas exchange, but definitely not enough, usually to meet the demands of our patient. And causes of this, the big one, again, is left-sided congestive heart failure, specifically if they're going into a cardiogenic shock, and we'll talk about that here in a little bit. This could be a basic lung infection, right? We can have a pneumonia where we actually have pus that's actually in our lungs due to some kind of irritant or some kind of infection where the body's trying to fight that off, and unfortunately it's filling up our lungs with fluid. For near drowning, I don't want you to put drowning yet, and I'll explain why when we get to other hazards, lectures, and whatnot. But drowning, if we do have some kind of fluid that gets into our lungs, specifically, we'll talk about the difference between cold water and salt water drownings later on the semester. But if we do have fluid into our lungs, obviously we're not going to be able to get that good adequate gas exchange. We could have it from toxic reactions. This is basically from smoke inhalation. And now this could be acute. Let's say you guys, for whatever reason, unfortunately you are involved in a fire, and you guys have breathed in too much of that toxic fumes from whatever's burning. This can cause fluid in the lungs, and again, this is the body's way of trying to prevent the lungs from drying out if the air is superheated. Or this could be from years and years and years of abuse from tobacco or whatever else you guys are smoking. And this could also be from pregnancy, and we're going to talk about pregnancy later on when we get to our OBGYN lecture. Some signs and symptoms that we're going to find with our patients with actual fluid in their lungs is they're going to be extremely short of breath. And the best way to combat that is sitting the patient upright. We talked about this a little bit already, but remember, if your patient's laying flat and they're short of breath, the first thing we want to do is sit them up. And the reason why we're doing that again is because if your patient's laying flat and they do have fluid in their lungs, okay, the fluid is actually covering more surface area of that lung while they're laying flat, which is hindering gas exchange, right? Because we have fluids covering the whole base of the lung, we are not recruiting all those alveoli that fluid is sitting, or that of the alveoli that are underneath that fluid. So if we sit them up, if we sit our patient up, that fluid's going to drain only down to one lobe. So we're actually using gravity to help us out in this. We'll sit the patient up, that fluid's going to drain to the lower lung, and we're actually going to be able to recruit more alveoli than if they were laying flat. Okay. We could have what we call wet lung sounds, and these are different examples of wet lung sounds. Fine crackles are what we call rails. That's like if you guys have a bowl of Rice Krispie treats, right? Or Rice Krispies, the cereal, and you pour milk on it, you hear that snap, crackle, pop. That's what it sounds like. Or what they really say what it sounds like is if you guys put on your stethoscope and you rub two pieces of hair together, that's kind of a fine crackle situation. That's what it kind of sounds like. Coarse crackles, technically, is that more of that snap, crackle, pop from pouring milk on top of the Rice Krispies. And we can also get wheezing. And again, even if it is pulmonary edema, if we do hear wheezing, we're still going to treat this person with albuterol and possibly even ipratropium in order to try to get that wheezing to stop, in order to kind of open up those lungs, in order to guarantee the good ventilation, that mechanical movement of air in and out of the lungs for our patients. If it is really bad, and I'm talking really bad, we can develop pink frothy sputum. And this is fluid in the lungs that have been there for quite some time. And because it's been there for quite some time, it has engorged the actual capillaries that are surrounding our alveoli, and now our capillaries are actually starting to bleed. And it will look like this kind of pink frothy sputum when they actually like cough or spit up. Okay, so what's our treatment for this? Basically the same treatment just like we're doing with any other respiratory illness, okay? We want to make sure that we're getting good oxygenation and ventilation. All right, we want to make sure that the patient's able to move that air in and out of their lungs, that their skin color kind of starts to improve for us, that their oxygen saturations are right around that 94%, or at least above 90% in this case. So we want to give that high flow oxygen, that non-rebreather, anywhere between 10 and 15 liters. Again, I'm going to teach you guys to go big or go home. Okay, I want you guys aggressive with your respiratory treatment. So let's go straight to 15 liters of oxygen on the non-rebreather. And let's sit them up, guys. Let's sit them up. It's hard for us to sit them up with their legs dangling in the back of the ambulance, because technically when you guys get into your services, everybody needs to be placed on the gurney appropriately and strapped into the gurney appropriately, but there are some times that you guys might have to sit them with their legs dangling in order to kind of help that fluid drain a little bit. We gotta hustle. We gotta get to the hospital. Okay, not necessarily a code 3 transport to the hospital, but let's not stay on scene and play. Okay, let's get this patient to the back of the ambulance. Let's take them to our office where we are comfortable. And let's make sure that we start treatment that way. And we really want to do a focused history and interview of the patient to make sure that we are doing a good sample. We're doing a good OPQRSTU, making sure that we do know that, like, some of the medications that this patient takes, so that we can kind of figure out what might have happened to this patient. How do they get that pulmonary edema, whether it's a chronic issue because of other disease processes that this patient might have, or if it's something that could be an acute. Did they actually breathe in some kind of toxin that may have led to this? Okay, moving into emphysema. Remember, emphysema is in the class of COPDs. Okay, same with asthma, right? Asthma is a COPD. Emphysema is a COPD. Okay, chronic obstructive pulmonary disorder. Basically, emphysema is a chronic disease from years and years and years of retained lung gases. Okay, basically this is our smokers. Okay, long-term exposure to superheated gases plus toxins. The problem with emphysema is that they have actually lost the surface area of the alveoli. I already mentioned this before, but let's talk about this again. When you guys smoke, and maybe you guys have never smoked in your life, good for you. Maybe you guys are currently smokers, but when you guys smoke and you guys inhale, you guys hold your breath for a little bit. Well, when you're holding your breath, you are actually increasing that intrathoracic pressure, not letting those lungs kind of expand and contract the way they're supposed to. So again, I'm going to use this. You're going to hear this again and again. If you guys take a rubber band, right, and you put in 2 fingers and you keep stretching out, in and out, in and out, in and out, in and out, right, and you keep stretching that rubber band, eventually that rubber band is going to lose its snap. Okay, from years and years and years of multiple times of abuse, of more abuse than the actual lungs are are used to. Okay, so in this picture here, you guys can kind of see the good lung on the right hand side. You guys can see what those alveoli kind of look like, and then the bad lung on the left side. And basically what it is those alveoli are not able to contract. They're kind of stent open and they're damaged. They're not able to contract in order to help with adequate gas exchange. Okay, so we call our emphysema patients pink puffers. Okay, and we call them that because they do what's called pursed lip breathing. You guys can kind of see this gentleman performing pursed lip breathing in here. They'll breathe in, and when they breathe out, they'll actually kind of put their lips together and breathe out through their lips. So it's, and what they're doing when they do that pursed lip breathing, we've talked about this already a little bit in the other lectures, but when they're doing that pursed lip breathing, they're trying to create back pressure in their lungs. Okay, so because their alveoli can't snap shut or snap closed, right, in order for that gas exchange, they're constantly stepped open. We're trying to do a little bit of back pressure in order to help try to achieve that gas exchange for our alveoli. Okay, you guys can also do this to your patients when we actually put them onto a CPAP. That's basically what you're doing, is you are trying to create a back pressure in order to stent those alveoli open, in order to force those oxygen molecules into the blood supply in order for adequate gas exchange. And we call them pink because usually the rest of their body is extremely pale, except for around their face and neck. This is a perfect example of a pink puffer. Okay, no guys, this is not a sunburn. Okay, this is not years of sun exposure or anything like that. This is due to the disease process. This is the people that are no longer breathing to blow out CO2. They're actually breathing in order to get oxygen. Guys, I did skip ahead a slide, but remember that usually with emphysema, the number one reason why people get emphysema is because they are or were smokers at one point in their life. And it doesn't matter what, pipe tobacco, cigarettes, cigars, whatever. If it's some kind of toxic inhalation that they have exposed themselves to over and over and over again, they can develop emphysema. People that smoke marijuana can develop emphysema. People that smoke crack can develop, or meth, right? Anybody that's smoking something that should not be in their body can develop an emphysema. Signs and symptoms. You got the pink puffer. You guys saw that in the last. Slide. They'll be short of breath, usually in that tripod position, and we've already talked about tripod, so I'm not going to talk about that again. They could have very rapid and shallow breathing, and usually it's because they're in the tripod position that they're doing this. So let's try to get them out of that tripod position. Let's try to have them sit back in their chair so they can get that good fill, nice chest expansion, in order for them to help out, maybe not use as much muscles as they would, or not enough, a lot of energy while they're in the tripod position, in order to kind of slow that breathing down. We could have wheezings and crackles. Okay, usually that wheezing and crackles are going to be found in the kind of the lower airways. Specifically, the crackles will be found in the lower airways, but they could technically be found all over the lungs, depending on how far into the disease process somebody is. They're going to be very thin. They could look emancipated, right? They could look like they are dying of starvation, right? They're really not. It's just how their body is now processing respiration for them. They'll have a barrel chest, and we will talk about barrel chest here on the next slide. But basically, barrel chest is where the front and the back distance is as big as the width. Their chest looks like a barrel. Okay, that is the number one sign of emphysema. You guys will be able to see that from here on out, the rest of your careers, whether you guys become EMTs or not. You guys will always be able to see a barrel chest walking through Smith's or Walmart or something like that, right? And then we also have something called clubbed fingers, and the clubbed fingers is actually it's a symptom of a disease process, and it's usually caused by chronically low levels of oxygen in the blood. And I have a picture coming up of clubbed fingers for you guys here in a sec, so you guys can see it. These people, if they are diagnosed with emphysema, they are more than likely on home oxygen. Okay, so if they are complaining that they are short of breath, let's still take them off their own home oxygen, because that stuff's expensive, guys, right? Let's use our oxygen for the patient. But the big thing is, and I know this sounds really stupid, but it's definitely something that you guys need to look for. You need to make sure that there's no kinks in their oxygen tubing, and you need to make sure that the actual machine is on. Okay, a lot of these people just forgot to turn their machine on, right? And they think they're breathing in oxygen, and they haven't been breathing oxygen for hours, or maybe during their sleep, while they were sleeping, the oxygen container ran out of oxygen, and they didn't by chance hear the alarm of the oxygen tank when the oxygen ran out. And most of the time, they just need to kind of get caught up on some oxygen intake. So make sure that you guys are kind of looking for the obvious, specifically when it comes to any respiratory patient. If they're on oxygen, let's look for kinks in the tubes, knots in their tubes, because these people are going to be on these nasal cannulas with 40 feet of tubing, right? And they designed that so they could still move around their house, right? But they could develop kinks, they could accidentally get a knot tied in it, or they could have run out of oxygen or forgot to turn their machine on. And again, just like any other respiratory illness, just like any other COPD, these people call 911 when they have already exhausted all treatment options for them at their own house. They have taken their meds. They have taken their inhalers. They have cranked up their oxygen a little bit more than they're supposed to be doing in order to try to catch that breath. It's still not working. It's still not working. This could have gone on for hours. This could have gone on for possibly days. And as soon as you guys get on scene, we are behind the 8 ball. That's why I want you guys aggressive with your oxygen therapy. Okay, so barrel chest, that's what it looks like. It is the from front to back is the same distance as they are wide. It's one big circular barrel type chest. When we are talking about pursed lip breathing, again, they're trying to increase that intrathoracic pressure. Okay, so they are kind of trying to develop that own back pressure in order to help with the actual gas exchange. And they breathe in normally, and then they kind of purse their lips together and breathe out through like a really smaller hole as pursed lip breathing in order to try to maintain that back pressure in order to try to help with actual gas exchange at the alveoli level. And then, as promised, here is the picture of the actual clubbed fingers. It looks like the actual fingernails themselves are going to start popping off of your patient's hands. The actual tips of their fingers also are actually fatter than the rest of their fingers. And again, this is a disease process that's not necessarily associated with emphysema. You will definitely see it in your emphysema patients, but there are other disease processes, and we'll talk about those later. There are also disease processes that can have clubbed fingers, but this is just due to chronically low levels of oxygen in our patient's blood, and this is usually from years and years and years of chronically low levels of levels of oxygen in the patient's blood. So how do we treat it? Well, just like we're going to treat any other respiratory disease, guys, let's give them some oxygen, okay? Usually we don't have to go straight to the non-rebreather on these folks, okay? Usually a nasal cannula anywhere between 1 and 6 liters per minute does wonders for these people, okay? Remember, they're breathing to get oxygen, not necessarily to remove CO2. So normally, because of the disease process, we do not want, these patients might normally sit at like 88, 86, 87%, somewhere around there in their oxygen saturation. These technically are people that we necessarily do not want to get them up to 94%. Okay, we can actually do damage if we get them up to 94%. So this is why we want to do a real focus history on our patients. Most of these patients do own an oxygen saturation in order to monitor their oxygen saturation at home. We want to find out what their levels usually are, right? Ask them, hey, my friend, what is your pulse oximetry normally? What is your oxygen saturation normally? We want to try to get them back to their normal, right? And a nasal cannula does very good at getting people back to their normal, okay? Again, though, never withhold oxygen to people that need it, okay? If we get them back to that normal and they're only at 88%, they still say they're short of breath, well, damn it, let's increase that oxygen, right? Let's bump them up to 90. 91, 92, or if we need to, let's go all the way to 94, 98%. It doesn't matter. We're going to listen to our patient. Okay? We do not treat numbers in EMS. We treat signs and symptoms, period. We'll leave the number treating for our nursing friends. That's why they make the big bucks. Okay? We treat signs and symptoms. If your patient is saying they are short of breath, they are short of breath until proven otherwise. Okay? We can assist with their inhalers only if it is a bronchodilator. So basically, only albuterol. And again, we can give them our own albuterol. Let's leave their albuterol at home. So first of all, A, we don't lose it, right? And second of all, we're patient advocates, right? We can use our own equipment. We'd not necessarily use the patient's equipment, okay? The other thing to keep in mind, specifically when we're dealing with somebody that's on oxygen, is let's make sure that when we transport, we take a spare oxygen tank with them so that they have a way to get home, okay? Let's not just take them to the hospital without their oxygen, because guess what? In our busy system, if we take the patient home, or if we take the patient to the hospital without their oxygen, we are also going to have to transport that patient home on oxygen in order to get them to the oxygen that we left there in the first place. So let's make sure that we bring their carry-on little small oxygen container so that they can get home without having to take an ambulance, okay? Go, guys. Again, we are dealing with a respiratory problem, right? And we do not want to get behind the 8 ball. Let's get these people to the hospital. Let's not sit there and play on scene, okay? If we're really far out and our ALS or ILS intercept is closer, maybe let's think about doing that, okay? Again, this is a judgment call, guys. This is something that you guys are going to start becoming very comfortable with as you guys put in some experience on the streets. Okay? For my class, for this class, nope. We're going to transport. We're not going to sit there and stay on scene. Let's get this patient to the back of the ambulance. Let's get this patient to our office. Let's get this patient to our controlled setting. And let's start working on our patient in order to try to stabilize them. If they are in respiratory distress and we are hearing wheezing, absolutely, let's give them some albuterol. Okay? Go straight to 5, guys. 5 milligrams of albuterol. Okay? We are going to talk about something that's called cardiac wheezes when we get into our cardiac emergency section. We don't want to give albuterol to cardiac wheezes. And again, we'll talk about that when we get to cardiac emergencies. Okay? But we want to make sure that if we are hearing wheezes in our patient, they are complaining of shortness of breath, we want to give them that albuterol in order to get those bronchi to really dilate in order to help with the ventilation of the patient.